open this public hearing of the House of Representatives Select Committee on Mental Health and Suicide Prevention. I'm the committee chair, Fiona Martin, member for Reid. In the spirit of reconciliation, we acknowledge the traditional custodians of country throughout Australia and their connections to land, sea and community. We pay our respect to their elders and past, present, and extend that respect to all Aboriginal and Torres Strait Islander peoples today. While the committee had planned to hold this public hearing in Melbourne, COVID-19 travel restrictions have meant that the hearing is now being conducted via video conference. In accordance with the committee's resolution on the 24th of February 2021, this hearing is being recorded and broadcast on the Parliament's website, and transcripts of proceedings will be published on the Parliament's website. I remind members of the media who may be listening online of the need to fairly and accurately report the proceedings of the committee. Please note that the committee is unable to intervene or provide advice in relation to individual circumstances. So if you are in immediate danger, please contact 000. If you or someone you know needs help, please contact Lifeline Australia, Suicide Callback, Kids Helpline, Beyond Blue or eHeadspace. Transcripts of today's proceedings may not be available in time to meet the deadline for questions or notice. Therefore, could you please keep track of any questions or notice so that you are able to respond in the time required. Now, I'd just like to acknowledge my colleagues on the line, Ms Templeman, Ms Stanley and Mr Connolly, who are committee members. Today, we welcome the Trans Health Research Group, LGBTQI, Health Australia and Sex Gender Education Australia to give evidence before the committee. For the benefit of Hansard, could you please state your full name and the capacity in which you appear before the committee, starting with your Trans Health Research Group?
My name's Ada Chung. I'm a clinician researcher and endocrinologist from the Trans Health Research Group. Thank you.
Thanks, Ada. Hi.
Hi.
My name is Savs Vickle. I'm a researcher with the Trans Health Research Group as well.
My name is Zed Tintor. I'm the Deputy CEO of LGBTIQ+ Health Australia.
Hi.
I'm Nikki Barth. I'm the CEO of LGBTIQ+ Health Australia.
Hi, Nikki.
Hello.
Is that everybody? Tracy, is it?
Hi, I'm Tracie O'Keefe. I'm a clinical psychotherapist. I'm a sexologist. I'm representing Sex and Gender Education Australia.
Fantastic. I think we've got everybody. I remind you that although the committee does not require you to give evidence under oath, the hearings are legal proceedings of the Parliament and warrant the same respect as proceedings of the House. The giving of false or misleading evidence is a serious matter and may be regarded as contempt of Parliament. So before we begin with questions and discussion, would you like to begin with an opening statement?
Thank you. Good morning, everyone. I'm Ada Jung, and thank you for the invitation for Savs Vickle and I to speak today. We too wish to acknowledge the traditional custodians on the lands on which we all meet. We are clinician scientists from the Trans Health Research Group at the University of Melbourne. Our expertise is community-led research to improve the health and well-being of the transgender or trans community. Being trans is part of the natural spectrum of human diversity. The WHO and others have clearly stated that being trans is not a mental health disorder. There's nothing inherent to being trans that makes a person more likely to experience poor mental health. Our research has shown that in trans Australians, over 70% have depression and 43% have attempted suicide. They are arguably one of the most socially and medically marginalised groups in Australia. As a doctor, I've sadly seen this firsthand. Unemployment, which is 3 times higher than the population, experiences of physical assault, discrimination, including when simply trying to see a doctor and being unable to access gender-affirming hormones and surgery all contribute to suicide risk.
My paper has shown that COVID-19 has worsened the health disparity. In addition to the stress of the pandemic, trans people describe being stuck at home with transphobic household members and loss of support. 61% were clinically depressed and 49% experienced thoughts of self-harm or suicide in the early months of the pandemic. This is fourfold higher than the general population and higher than before the pandemic. The mental health needs of the trans community are not being met by mainstream services. Misunderstanding or misgendering of a trans person in a moment of crisis will exacerbate distress. Because of this fear, most rely on LGBTI organisations who can't keep up with demand. There is an urgent need for expansion of services tailored to the trans community, such as QLife and Discharged, and a need to consider novel interventions that are co-designed with the community. We as a society need to reduce discrimination. Additionally, research in trans health and suicide prevention must be prioritised to reduce health disparity and measure the success of targeted interventions to reduce suicide. Thank you.
Thank you.
Well, I might start by asking some questions, and I'll just
Do I need to make an opening statement?
Oh, Tracy, if you have an opening statement, please, by all means, yes.
I do. I'm Tracie O'Keefe. I've been involved in mental health and suicide prevention for people from sex and gender diverse communities, which includes people who are intersex, sex non-specific, transsexual, transexed, transgendered, non-binary, and culturally sex and gender diverse since 1973, and been in practice for decades, seen over 3,000 patients in clinic. We're at the end of a 3-year study on global occurrence of suicidality in sex and gender diverse groups. We know very much that minority stress is the major cause of suicidality. In some of the international studies, it's up to 70% of suicidal thoughts and up to 50% of the first suicide attempt. Many suicides are not registered as suicides for people from sex and gender diverse groups because their families obfuscate that fact. There are problems, particularly in Australia, where we have a very transphobic government at the moment. So let's not pretend about that, and that the laws need to be changed to reduce discrimination. So there are major problems with trans people getting help. In some quarters that provide help to this group of people, they have to wait 6 months for an appointment. 6 months. If you're suicidal, you need attention immediately, not in 6 months' time. Suicide is not a mental illness. It's a life crisis, like divorce or bereavement. It's a stress reaction, which can be got over quickly if a scaffolding approach is taken, not a sticking plaster approach. Thank you.
Thank you, Tracy. So we've heard from the Trans Health Research Group and now Dr. Tracie O'Keefe from the Sex and Gender Australia. Would Nikki Bath or Zed Tinter like to make an opening statement from LGBTIQ Health Australia?
Yes, please. Thank you very much. Good morning, and thank you for inviting us to speak with you today. I'd like to acknowledge the traditional owners of the land on which we're all meeting. I'm on Gadigal land of the Eora Nation and pay my respects to elders past, present and emerging and any Aboriginal people here today. As you'll know, LGBTIQ+ Health Australia is the national peak health organisation in Australia for organisations and individuals that provide health-related programs, services and research focused on lesbian, gay, bisexual, transgender, intersex and queer people and other sexuality and gender diverse LGBTIQ plus people and communities. We welcome the opportunity the Select Committee on Mental Health and Suicide Prevention provides for us again to highlight the mental health and suicide crisis that our communities continue to face. And I'm not going to use this time to talk to the data and evidence that's been provided to you in our written response to the committee or the ongoing impact of COVID-19, but rather I would like to highlight to the committee that despite significant inquiries and processes exploring and highlighting the significant mental health and suicide risks for our communities, little, if anything, has changed. And I hope very much that this committee's processes will amount to real change for our communities. Despite feedback and recommendations to, for example, the Productivity Commission report and the final advice to Christine Morgan in her role as National Suicide Prevention Advisor to the Prime Minister, responses to our community's needs are not sufficiently robust, if indeed acknowledged at all. We are continually seeing investments into larger scale generalist mental health services at great cost to our community-controlled LGBTIQ plus health organisations across the country who desperately need investment so that they can meet demand and expand. We need better data, and as you will no doubt be aware, there will not be any variables included in the census next month to capture population level data for our communities. We acknowledge the ABS 2020 standard for sex, gender, variations in sex characteristics and sexual orientation. And it is only with these variables embedded into all health and social services minimum data sets, including in coroner's data, that we will be able to benefit from responses such as the National Suicide and Self-Harm Monitoring System. Our communities remain on the back foot when compared to the broader community, as the data renders us invisible. Generalist investment sidelines our community-controlled organisations, and there continues to be a lack of national coordination. We continue to live in a society where the well-understood causes of minority stress, such as interpersonal prejudice and discrimination, remain present, particularly for our trans and gender diverse communities, as has been just highlighted by my colleagues. Where despite best efforts of intersex human rights defenders, discrimination, stigmatisation and human rights violation, including harmful practices in medical settings, continues to occur in Australia. And it would be remiss of me not to refer to the ongoing mental health harms that continue to impact our communities due to the ongoing religious discrimination bill. There are many issues surrounding our communities, and we must be regarded as very much part of the solution. In closing, I'd like to reflect on an experience I had last week while participating in an online LGBTIQ plus specific consultation on the next national plan to reduce family, domestic and sexual violence. Jo Ball, CEO of our full member organisation Switchboard Victoria, stated that in our communities, our family violence murders are the suicides of people in our communities who feel as though there are no alternatives for them when experiencing family violence. It was a powerful statement of fact, and Australia can do much better than this. We ask that this committee use its position to hold up the needs of our communities and make practical recommendations that will result in building a strong and responsive LGBTIQ plus community-controlled health sector. Will provide us with much more robust data by making it so that the ABS 2020 standard is included in minimum data sets and across all research, and that there is a national commitment to the coordination of investment and outcomes for our communities. Thank you.
Thank you very much. I'll start by asking some questions to people here today. Thank you. And thank you very much for your evidence. Obviously, the LGBTIQ committee is a at-risk group. The largest ever national survey found that 10% of LGBTIQ plus young people had attempted suicide within the past 12 months, while 25.6% had attempted suicide at some point in their life. The Trans Health Research Group noted that trans Australians were disproportionately affected by COVID-19 pandemic, with its survey finding that 61% were experiencing clinical symptoms of depression and 49% had suicidal thoughts or intent in the previous 2 weeks. The group recommended that the government support and fund the expansion of existing crisis support services that are tailored to the trans community. My question to you is, what are the unique needs of the trans communities and what is required to deliver effective mental health services and treatment. And as previous submitters have spoken about, particularly services in regional areas, is that social infrastructure that's required in communities and engagement strategies to keep people connected. As you know, because loneliness, particularly in this particular at-risk group, I think is probably more prevalent than in other groups within Australia. So I throw it to you. Perhaps we'll go in order. Dr. Ada, would you like to start?
I'll let Sav Zwickels speak to this.
Okay.
Thank you. I think the issue with mainstream services is there's not enough training or understanding of, in particular, trans and gender diverse experiences, as well as other experiences within the LGBTI community. And so people who are trans and gender diverse or other members of the LGBTI community, they turn to LGBTI specific services because that's where they're going to feel most safe. And in a moment of crisis, the last thing a person wants is to be misgendered or to be asked inappropriate questions because the person that's picked up the phone simply doesn't understand what it means to be trans. The issue, LGBTI services are just so underfunded, and they were before the pandemic and even more so now. So as I think Tracy mentioned, waits are up to 6 months. I know that many services just cannot take on new patients at the moment, so they're turning people away, and people are calling multiple services and just not getting anywhere. So these are issues that really need to be addressed in funding, in resources for LGBTI specific organisations. We have QLife, which is a national support service, counselling service, as well as web service. And we have Discharged, which is a peer support group for trans and gender diverse people who are experiencing thoughts of suicide to connect with others who are trans and gender diverse who are also experiencing suicide. And most of these services are volunteer run or running on minimal funding, and that's just not good enough. And I think going forward, new services, or when you're putting more funding into existing services, it needs to be co-designed with community. So that means speaking to leaders of community, speaking to people who are trans, who are also people living with disabilities, who are neurodiverse, who are immigrants, who are people of colour, who are First Nations people, and making sure that any service is accessible to them, that it feels safe and it feels appropriate and is fulfilling their needs.
I might add that data shows that 70% of LGBT individuals avoided services such as Lifeline because of fear of discrimination. And that just highlights the need for mainstream organisations to also upskill in providing safe and affirming, accessible mental health support. And in addition to existing services, we need to think of novel strategies to support people all over Australia. And whether that be having mental health services or case management remotely using video conference, or perhaps outreach after contact with a crisis support service, ongoing mental health support remotely, whether that be through video meetings or text messaging based interventions. With funding, I think such strategies using remote technology can be delivered to trans people regardless of their location of residence and help connect people to community.
Thank you. Did anyone else want to comment on that? Yes.
Yes. At the moment, access through GPs is 10 visits to a psychologist. It's a sticking plaster approach. It doesn't work. Also, sectioning someone and medicating them doesn't work, because once they leave that emergency psychiatric observation, They go back to the circumstances which caused the suicidation in the first place. The government has to take responsibility to change laws so that discrimination is no longer acceptable on religious grounds or any other grounds in Australia against sex and gender diverse people. That's a scaffolding approach. We need training of mental health professionals specifically in sex and gender diverse issues, not gay issues. En masse, intersex people do not use gay access health services, and many trans people do not use gay access health services because an intersex woman does not want to sit before a gay counsellor who doesn't understand anything about her issues. That's the scaffolding approach. We have 14,000 counsellors and psychotherapists in Australia who need Medicare numbers, which can help with this because many of them have training in suicide prevention in sex and gender diverse groups. That's a scaffolding approach. We also have the major problem. The volunteer section and the private section is a major support for trans, intersex, and sex and gender diverse groups. But Google presently blocks access. Now, the ACCC has done an initial report, but the government has done nothing. So private practitioners cannot advertise helping people with addiction or suicidation or depression or CBT. And Google has 92% of all online searches. So that's where people first of all go on their telephone for help. It's distorting our health system and stopping many people from sex and gender diverse groups getting the help they need fast. Further, that's a scaffolding approach. Further, we need that funding to community groups because traditionally, if you look historically, it's the community groups that has helped people go forward, overcome depression and suicide. And I'm going to quote a TV show. An internet show. One of the most profound shows that has shown this over the past year is the series Pose and the ball system in New York. Well, we ran that system in London, in France, in Greece, all over the world. It's been the community support that has helped people. So the government needs to give money to community groups to help people with depression and suicidation. That's the scaffolding approach. Thank you.
Can I just ask a follow-up question? You mentioned a number of occasions now changes to legislation. What specific legislation would you like to have introduced, or what changes to existing legislation would you like to see, if you could be specific?
It's at the moment there's a review of the Fair Work Act and the Sex Discrimination Act. In the Sex Discrimination Act, it gives religious exemptions. So somebody can say that they believe in Martians who are going to come and rescue the whole of the human race, and they can discriminate against sex and gender diverse people and also gay people. There is the online bullying bill, which is presently before Parliament. We don't know if they're going to put a religious exemption in that. There is the Latham bills in New South Wales, which are trying to change the education system, preventing teachers from teaching if they are trans or if they're gay on religious grounds. Australia is not a religious country. It has no official religion. It's a cosmopolitan country. Religious beliefs should not be an exemption from discrimination because we are signatories to the Human Rights Convention and we need to comply to those guidelines. Thank you.
Thanks. Okay, so I might just pass over now to Susan Templeman, who will have additional questions to ask. Thank you very much.
Thank you. Thanks, Chair, and thanks for your evidence. Thank you for the range of themes around affordability and accessibility and workforce capacity, legislative stuff, and also that more holistic approach in terms of the things you put in place to prevent suicide ideation as opposed to deal with suicide attempts. So I suppose I really want to dig, given this is a bit of a round table, I really want to dig a bit into the I guess the broader issues around. I'm trying to pull out the language. I think it was the multiple sectors beyond the health sector that we should really be looking at to build a community that is supportive of people from a wellbeing perspective. So I really want to throw that out and ask for your input in that around, what's your vision for how this all comes together?
Might I be able to start?
Sure.
Thank you. Thank you for the question. LGBTIQ plus Health Australia is the peak for LGBT. We have a broad membership base whereby we have our full members are the community-controlled LGBTIQ plus health organisations across the country. We have regular members who are unconstituted, really, organisations that are still working within health and wellbeing spaces. We have affiliate members who are organisations where they have specific programs funded to work with our communities, associate members who are people who are interested in working with our communities, and we also have individual members. The reason I say that is because it does, our membership does represent the large scope of organisations and individuals working with our communities in this space of mental health and wellbeing. At the heart of that, though, very much are our community-controlled organisations. They not only provide access to counselling and ongoing support programs, but they are also in the position to, where they run social connection, programs around social connection, where they link community members together and are able to work across the jurisdiction. Now, I've often said previously that you can judge our health by the health of our community-controlled organisations, and they're not in good health. They are constantly competing for funding from other large generalist mental health services and service providers. We are struggling to be able to meet demand. There's waiting lists, as already have been said to you, and it's not only meeting demand, these services need to be able to expand. And there's not jurisdictional equity across the country for these organisations. So we can see in places like New South Wales, where there's slightly better investment, we see the ability for increased programme delivery. But we see organisations struggling, particularly in the Northern Territory, WA, South Australia, and also even within Tasmania, although we're hoping that will change in time. So at a structural level, I suppose what I'm wanting to get across is that we need a really cohesive process where we can see national investment. I mean, we don't get peak funding. We have our bid in at the moment, as long as all those other organisations that are seeking for that precious funding. But we need jurisdictional joined up approaches so that we can see our organisations flourish across the country, because only when these organisations flourish will our communities flourish. I just really quickly also want to say that, at the moment, PHNs are undertaking the processes to develop their needs assessments. Many of them won't be able to access the data that they require, and we will remain invisible in those needs assessments. So the system in many ways is broken for our communities, and we do need some kind of national coordination, and we're asking for a 10-year national plan to be able to bring out where we sit within the existing national strategies so that we can understand what the priorities are, what the actions are, and we can start to evaluate it, because at the moment there is no joined up approach for our health. I just wanted to ask, Zed, sorry, was there anything that you wanted to add in relation? We have national coordination role for QLife, which has been mentioned, the teleweb and phone support service that runs every day from 3 p.m. to midnight. Was there anything you just wanted to add to the discussion so far with regards to QLife Z?
I think you're on mute. Either that or you're speaking very softly.
There we go.
Beautiful.
Better. Yeah, look, I think, yes, I would like to add to that, Nikki, thank you. And just if people, for those that might not know, so QLife provides an anonymous and free LGBTIQ peer support and referral for people in Australia wanting to talk about sexuality, identity, gender, bodies, feelings or relationships. So we're a telephone and web-based peer support and referral service. In our 20 to 21 data, we see 23% increase in callers and 13% increase to contact time on phone. The key reason for a call was loneliness and isolation being number one. And we saw also that family relationships moved to number 3 and previously was not in the top 10 at all. So I guess one of the key what that tells me is that there's also a significant percentage of unmet demand, and we do believe that it's important to have an increased investment to community-controlled organisations, as has been said before, such as QLife and Rainbow Door in Victoria. The staff that answer these phones have lived experience expertise, and to address the unmet demand and expand on geographical locations. I think also in terms of lived experience representation, that mainstream services to show a demonstrated commitment to collaborate with LGBTI communities, and as been mentioned before, to ensure services are co-designed and co-delivered with people with lived experience, and the knowledge is embedded in all programs and service design and funding arrangements. In the most recent federal budget, we saw an increase to investment to teleweb services, and that's very much appreciated. QLife is able to benefit from a small percentage of that funding, but realistically that percentage will nowhere meet the demand that is required to appropriately support our communities. I also, when we talk about services that like Headspace, that will have an adult Headspace program, we really need to take those opportunities and work with those organisations to develop a more collaborative and coordinated approach.
And thank you for mentioning raising the peer, the lived experience and how peer support can come in. So, because that was one thing I did want to touch on. So thank you for addressing that. And Dr. Chung, I think you had your hand waving.
Thank you, Susan. And just to emphasise what Nikki and Zed have already said, I think our vision, and I think for most people, would be that trans people can turn up to their GP, their local GP, or any psychologist or any mainstream service to access care. And, you know, ideally, trans people will be in a society where they can live, work, rent a house, go to the supermarket without any fear of discrimination or abuse. But we're not there yet. And so because we're not there yet, right now, it's the community-controlled organisations that can work to prevent suicide and improve mental health and provide that peer support where people can go and get help and they know they'll be understood and be included and feel safe. And in Victoria, we've seen investment in a statewide training program for health professionals in trans health. So, you know, that's run by a community-controlled organisation, Thorn Harbour Health. And, you know, they've been operating for 12 months and their goal is to train GPs, psychologists, all health professionals in providing safe gender affirming care. And it's these sort of initiatives that can really, you know, that should be rolled out across Australia to try and improve services for the trans community.
Yeah, thank you. That paints a very clear picture of where we are now and where we'd like to be.
Thank you.
Thanks, Susan. Vince Connolly has a question.
Yeah, thanks very much, Chair. And I'm not quite sure exactly to whom this question should be best directed, but I'm happy to put it out there and whoever feels best placed to respond can do so. So the question I have is, I mean, it's obviously deeply troubling the information that you've presented, whereby really 1 in 4 young people who are LGBTIQ plus have attempted suicide at some point in their life. So absolutely, this is an area where we need to direct attention and move that dial. We've heard a little bit about methods by which you've suggested that discrimination could be reduced. And I just wonder, apart from discrimination, what other drivers have you identified that are sitting behind this currently quite terrible outcome, and what can we do about those other drivers?
I'm at the end of a 3-year research project on suicidation in sex and gender diverse groups. We have to come back to minority stress is the major driver. And we can only reduce minority stress by changing our protection laws. Also, social ostracization is a major problem. So I think what's really important is not only we just grants are given to large community groups, but to tiny, small community groups all around the country, because it is local communities that have the ability, yes, we're in COVID at the moment, but that will pass. It's local communities that have the ability to meet up. The danger zone when somebody is suicidal is 28 days after the first incident, when the brain begins to repattern itself. They need daily support of those 28 days, and only small local community groups can do that. Thank you.
Could I just add to that? I just wanted to talk a little bit about intersectionality, and many LGBTIQ community members experience prejudice and in relation to other factors such as Aboriginality, disability, age, race or gender, as well as the stigma of living with a mental illness. So in terms of the coexistence of these factors, I think having a more integrated holistic approach is really important when we look at designing programs to appropriately support people.
Yeah. Thank you very much for your submissions, and we very much appreciate you coming on today and presenting before the committee. I don't think I have any further questions, and I'm trying to be very good at keeping to time. So on that note, I'd like to just acknowledge that we've heard you today, and we're taking on board your comments. Thank you very much for your time. You'll be sent a copy of the transcript of your evidence when it becomes available, and you'll also have the opportunity to request corrections to transcription errors. If you have been asked to provide any additional information, please forward it to the Secretary within 7 working days. And please contact the Secretariat in relation to any other matters arising out of today's hearing. Once again, thank you very, very much for all your submissions and for your time here this morning. Thank you.